Hey everyone, welcome to The Explainer. If you're a medical student staring down the barrel of your surgery clerkship, or maybe a junior resident losing sleep over ward calls, you are in the exact right place. Today, we're going to completely conquer your anxieties about intestinal stomas. We're taking the 100,000+ North American ostomy procedures done every year and translating them into a tight, focused framework. We are covering the surgical mechanics, the physiological nightmares, and the exact protocols that your attendings will expect you to know. Let's get started. Okay, let's dive right into this with two high-stakes, real-world scenarios. We'll call these your night shift nightmares. First up, patient 1. She's a 32-year-old on post-op day 4 after a total proctocolectomy. She's dumping 2.8 liters of watery green output a day. Her potassium is totally tanked to 2.9, and her creatinine just spiked to 2.4. Then we have patient 2, a 68-year-old guy, post-op day 1 from a Hartmann's procedure for perforated diverticulitis. You get paged because his stoma face looks dusky black, and that darkness, it extends down below the fascial level.
Now, scenarios like these trigger instant panic on the wards, right? So here is the clinical puzzle you need to solve to survive that night shift. First, why will handing a pitcher of plain water to patient 1 actually make her severe dehydration so much worse? And second, for patient 2, does that dusky stoma mean you need to wake up the chief resident and book the OR for an immediate relaparotomy, or can you just sit back and observe it? Hang on to those questions, because the answers are literally the difference between a phenomenal save and a disastrous complication.
To solve those puzzles, here's our mental syllabus for today. Number 1, anatomy and a plumbing analogy. 2, ileostomy versus colostomy. 3, high output stomas. 4, surgical creation. And 5, complications and bedside management.
All right, kicking things off with section 1, anatomy and our plumbing analogy. We really need these basic science foundations to solve our cases.
Think of the human gastrointestinal tract as a massive, multi-stage water treatment plant. An ileostomy is like tapping into the main pipeline way upstream, before the water even hits the dehydration and filtration plant, which of course is your colon. Because you've externalized the terminal ileum, you've completely lost the ileocecal valve and that crucial aisle brake mechanism. That's exactly why the output is high volume, liquid, and incredibly acidic. It's packed with active, corrosive pancreatic and biliary enzymes. A colostomy, on the other hand, taps in downstream, after most of the water reabsorption has already happened, giving you low-volume, neutral formed output. And finally, a loop stoma is basically just a temporary bypass valve. It's installed upstream to divert flow, letting a freshly repaired pipe section, like a really delicate anastomosis, heal up in peace without pressure or contamination.
Moving right along to section 2, ileostomy versus colostomy. This is highly testable, high-yield board material. Your attendings will definitely expect you to know.
The contrasts here are actually pretty stark. A well-adapted ileostomy will put out about 500 to 800 milliliters a day, while a colostomy is only doing around 200 to 400. Anatomically, you'll typically find an ileostomy in the right lower quadrant and a colostomy in the left lower quadrant. But the absolute most vital difference here is the surgical design in relation to the enzyme content. Because ileostomy output is loaded with highly active, proteolytic digestive enzymes, it carries a severe risk of causing chemical burns to the patient's skin. To prevent that, a surgeon must construct an ileostomy with a 2 to 3 centimeter spout. A colostomy, which lacks those corrosive enzymes, can safely be created almost flush with the skin level. Keep that spout in mind. It's going to be super important when we talk surgical technique in just a minute.
Let's move into section 3, high output stomas. This is where the pathophysiology gets critical. And this brings us right back to our first night shift nightmare, which happens to be a classic attending pimp question. Why does giving a thirsty patient with a high output ileostomy a pitcher of plain water actually make their dehydration so much worse? Now, before we crack this physiological paradox, if you are finding this explainer helpful for your clinical rotations, please take a quick second to like, subscribe, and share this with your study groups. It really helps us keep producing these focused medical deep dives.
Okay, so here's the answer. Sodium dumping. If a patient with an ileostomy chugs hypotonic fluids, we're talking plain water, tea, soda, the intraluminal sodium concentration in their jejunum and ileum rapidly falls below a critical threshold. And because nature hates a vacuum, sodium diffuses down its concentration gradient directly out of the plasma and into the bowel lumen. Through the power of osmosis, it drags a massive amount of water right along with it. So simply by giving them plain water, you've just triggered massive sodium dumping, paradoxical worsening dehydration, and profound hyponatremia.
Now, what's really interesting here is the microanatomy behind how the enterocytes adapt over 2 to 3 months. In a newly created ileostomy, the gut adapts through villus hypertrophy and by upregulating SGLT1 transporters, the sodium-coupled glucose transporters. For these transporters to actually function and drive passive water absorption across the paracellular space, the ileomucosa needs a minimum sodium concentration in the luminal fluid of approximately 90 millimoles per liter. If the concentration drops below that 90 mark, the pumps completely fail, and water just flushes straight out into the ostomy bag.
So how do we actually fix this at the bedside? We used an incredibly effective tool developed in the UK called St. Mark's solution. It is a very precise recipe: 20 grams of glucose, 3.5 grams of sodium chloride, and 2.5 grams of sodium bicarbonate, all dissolved in exactly 1 liter of water. Why this exact mix? Because it provides that exact 90 millimoles per liter sodium concentration required to fire up those SGLT1 co-transporters, pulling water back into the body without causing osmotic diarrhea. It's essentially the ultimate hack for a high-output stoma.
Let's shift gears to the OR for Section 4, Surgical Creation.
First things first, we have to talk about the trophine, the actual hole created through the abdominal wall. Guidelines mandate careful preoperative sighting, passing right through the rectus abdominis muscle to cut hernia rates in half. But intraoperatively, the secret to success is something I'll deliver to you as a senior attending pearl: the 2-finger rule. When pulling the bowel loop through the fascial defect, your index finger should slide smoothly into the peritoneal cavity alongside the bowel, without squeezing the mesenteric vessels. If that trophine is too tight, you literally strangle the blood supply and cause ischemia. But if it's too loose, you're inviting early peristomal herniation and prolapse.
Once the bowel is safely pulled through that perfectly sized trophine, how do we actually build the stoma? Let's walk through the Brook and ileostomy technique. After marking the rectus muscle and vertically splitting those fibers, you pull 4 to 5 centimeters of distal ileum up through the defect. Remember our earlier rule about ileostomies and corrosive enzymes? This is exactly where it matters. You must use tri-point sutures, meaning you take a bite of the full-thickness bowel margin, then the seromuscular layer near the skin, and finally the subcutaneous skin. This everts the bowel, kind of like rolling down a sock, to construct a 2 to 3 centimeter spout. That spout is absolutely crucial because it directs the highly acidic proteolytic effluent safely into the appliance bag, completely bypassing and protecting the patient's skin.
Bringing the narrative full circle back to the wards, let's hit Section 5, Complications and Bedside Management. Let's look back at our second nightmare patient, the guy with the dusky black stoma on post-op day 1. How do you, as the resident on call, distinguish between a harmless superficial slough and a catastrophic internal emergency? You use the glass tube test. You grab an illuminated pediatric proctoscope or a clear test tube and gently insert it into the stoma, right there at the bedside. You're specifically looking at the mucosa relative to the fascia level. If the mucosa turns pink above the fascia, the ischemia is superficial. You can just observe and manage conservatively. But if that dark, dusky mucosa extends down below the fascia level, like it did in our patient, it means the bowel inside the abdomen is dead. That is intraperitoneal necrosis.
Under the Clavian-Dindo system, which is the standardized tool for reporting surgical complications, necrosis extending below the fascia is categorized as a grade 4 complication. Why? Because dead bowels sitting inside the peritoneal cavity rapidly leads to massive fecal peritonitis and sepsis. It is an absolute non-negotiable indication for immediate surgical re-exploration.
So the crucial point here is how applying these physiological frameworks and clinical protocols successfully resolves our initial night shift nightmares. For patient 1 who was dumping nearly 3 liters of fluid, we now know she was suffering from sodium dumping. Giving her plain water would have totally destroyed her SGLT1 transport gradient. What she really needed was fluid restriction of hypotonic drinks and the immediate initiation of the St. Mark's solution to reestablish that 90 millimoles per liter gradient. For patient 2 with the dusky stoma, utilizing that bedside glass tube test allowed us to confidently identify intraperitoneal necrosis, a grade 4 complication, and rush him right back to the OR to prevent fecal peritonitis. Boom, you've officially navigated the shift.
But before we wrap up this explainer, I want to leave you with one final thought about late complications. Remember the loop stoma we talked about earlier, the temporary bypass valve? Surgeons often place a plastic rod or bridge underneath it to keep it from retracting back into the abdomen. If that bridge is designed to relieve pressure, what kind of catastrophic local pressure necrosis and skin breakdown do you think occurs if you forget to remove it by post-op day 10? Keep asking these kinds of mechanical questions because mastering the plumbing is exactly how you master surgical physiology. Thanks for learning with us today.